Hello, this is John V. with Rhine Medical. The purpose of this videotape is to discuss the features and benefits of the new Rhine 3D Diamond Blade, also to explain some of the recommended uses of the blade, and also some of the recommended sterilization procedures for the new Diamond Blade. First, we're going to talk about a little bit of theory, though. You see before you an artist's rendering of the new 3D Diamond Blade. The rendering on the left shows the top or anterior view of the blade, and the drawing on the right shows the bottom or posterior view of the blade. The most immediate thing noticeable would be the differentiation in beveling. You can see that the bevels on the top of the blade are almost the reverse of those on the bottom of the blade, both in the front bevels as well as the side bevels. Note that here the bevel becomes wider as it goes closer to the shoulder, and just the opposite on the bottom of the blade, where the bevel actually gets thinner as it approaches the shoulder. Likewise with the side bevels. This side bevel is thinner than this side bevel. These bevels are designed to automatically compensate for incising a spherical object at an angle other than 90 degrees. Here's a front profile view of the blade. This is a conventional blade that is sold now on the market. You can see that the beveling is symmetrical as you look at it from the front on. However, when you look at a 3D diamond blade from the front profile, you will see that these front bevels slant or graduate downward, and it's this feature that allows a surgeon to advance this blade in a linear fashion through stroma to achieve what we would call a linear perpendicular incision. Now these incisions are presented here at the bottom. This is the typical smile type of incision that you'll see through Bowman's and Decime's when using a conventional diamond blade. However, in this rendering on the right, as the surgeon advances this blade in a linear fashion, you can see the result, a linear perpendicular incision through Bowman's as well as through Decime's. Now let's talk about the two different styles of 3D diamond blades. This particular blade is available on both a step handle, which is pictured on the right, and an angled handle, which is pictured on the left. Both are retractable. First, let's talk about the step handle. The reason we call this a step handle is because it has preset calibrations already engineered into the handle. Those calibrations are set at 300 microns, 400 microns, 500 microns, full extension, and full retraction. For example, when setting this blade to full retraction, you can see two small flat ridges right here and here. And I'm going to try and focus in here to make it easier to see this. Okay. You can kind of see these flat ridges here. When these two ridges are lined up, it means the knife is in the retracted position. However, you can also see, hopefully, well, not very well, but there are numbers right here which represent the setting, the pre-calibration setting. For example, this number reads 4.5, which means when you line up that number to that flat ridge, the blade is extending 4.5 millimeters beyond the foot plate, as you can see here. Likewise, when you turn this to 0.3, that would be a 300 micron extension, 0.4 would be a 400 micron extension, and 0.5 would be 500 microns or 0.5 millimeters of extension beyond the foot plate. And that is presented here. You can see the blade extending beyond the foot plate, in this case 500 microns. Now the reason that this blade is available on this particular handle is so that surgeons can perform a groove step incision, which involves setting the blade at one of these calibrations, 3, 4, or 500 microns, creating a groove incision, and then setting the blade to full extension for entrance into the anterior chamber. Now there is one key regarding the usage of this blade in this handle configuration. When making the groove incision, you always want to keep the foot plate on the bottom and keep the blade on the top. This is for full visualization during the fashioning of the groove. And that's done simply by pushing the blade down into the sclera or cornea and making a linear groove. After the linear groove is fashioned, the blade is advanced to full extension, and what's critical here is to turn the knife 180 degrees so that the foot plate is on top. That is critical because this is the anterior side of this blade. You always want to make sure that the foot plate is on the top when tunneling into the anterior chamber. Again, when setting the groove, place the foot plate on the bottom and make sure that the blade is on top, set the groove, and then go ahead and advance the blade to full extension and turn the knife 180 degrees so that the foot plate, the single foot plate, is on top. At this point, the blade is inserted into the posterior segment of the groove and then advanced forward. The bevels will do all the work for you. The key to this blade is not to change the plane of the blade when it's going through tissue. The surgeon will simply locate the position where he or she would like to enter Descemet's membrane, point the tip of the blade to that position, and advance the blade in one plane. And do not move the blade side to side because you can also cut. Obviously the bevels are sharp on the side edges, so you'd want to go in one straight motion and pull out in the same motion. All of the work of this blade is done in the front bevels. Now, in the event that a surgeon has a small phaco-tip, like a 2.6 phaco-tip, and he's going to use a 3.2 millimeter implant, meaning that he can get that implant through a 3.2, I would recommend getting a 3.2 blade. The blade is available in a 2.5, 2.8, 3.0, or 3.2 millimeter width. The reason I recommend matching this blade to the IOL rather than the phaco tip requirement is because all of the work is done by the front bevels. That means that you're relying on the front bevels to compensate for all of the incision architecture. So you always want to match the blade size to the IOL incision size, not to the phaco-tip size. What I would recommend is advancing the blade in the event that a surgeon is using a 2.6 millimeter phaco-tip. Advance the blade not quite up to the shoulders so that the incision, the internal incision, is smaller than the external incision. Remember, by definition, all blades, all keratomes are trapezoidal in nature in the front. And I will show that here. This is a trapezoidal blade when you look at this portion of it. So I would recommend advancing this blade only up to this point if a surgeon is using a smaller phaco-tip and having trouble with BSS leakage. And then after the lens is emulsified and IA is performed, I would reinsert the blade all the way through and insert it past the shoulders to gain the full effect of these bevels. Now, just the opposite would result in probably incision that would be straight and then tagging up like that. In the event that you were to purchase the 2.5 millimeter blade, you would inevitably have to move that blade from side to side to accept a 3.2 millimeter incision requirement for the implant. And that's where, when you move the side bevels to the side, you would get a little bit of tagging, such as this. That's why we recommend buying the size blade that will accommodate the implant in its folded position. Now the angled handle. You can see that this has a stop on it here. That's to prevent the blade from advancing inadvertently. and you can just turn it to the right to eliminate that stop, and then push forward, and then again to the right, and then retract it slightly, and it's locked into position. This is the angled handle, which is angled at approximately a 25-degree angulation. This blade is already set so that the anterior portion is obviously on the top and the posterior portion is obviously on the bottom. Both of these handles are made of titanium. The components are made of titanium, the springs, so that we do guarantee the handles for life. With this particular blade, it's actually very handy to have because you can move around the clock with this blade without having to worry about any type of high brow or a deep set eye or anything. You can move around to attack a steep meridian and make the incision wherever you like because of the angle. You won't have to turn the eye down with this. So you can see that some of the bevels now are shining a little bit, but that's really the front bevels are what is making this blade do what it does. Okay, now a couple of words about sterilization. First of all, I would never hand a surgeon a blade that's exposed. I would always hand him or her the handle in the fully retracted position and let the surgeon advance it. And I would recommend that nurses or assistants not hand the blade to the surgeon in the advanced position. That way all of the responsibility is on the surgeon. Sometimes these can be dropped or touched up against another instrument, and if you have it in the fully retracted position, it doesn't matter because the blade will be protected. So I would hand the blade or the knife to the surgeon in the fully retracted position, let the surgeon turn it and advance it into the position that he or she wants. Then the incision is made, and then the surgeon should retract it back into the housing and hand it off to the assistant. Most of the accidents that occur happen during the autoclaving process or when the blade is on the tray and other instruments are put on top of it. This causes all kinds of problems with blades chipping and so forth. So the key to the sterilization process is never allow anyone to touch this knife unless it's in the fully retracted position. Likewise with the step knife. You can see that it's in a fully retracted position now, so I would recommend that this knife be handed to the surgeon just like this, and then let the surgeon advance it to whatever setting that they want, and then when they're done, advance it back or retract it back into the housing and hand it off to the assistant. These diamond knives can be autoclaved and sterilized in any manner. One of the things I recommend is that if a surgeon is going to be using this knife all day, after the first use I would retract it back into the handle, place it in a pan of water just so that debris is not allowed to form on the blade. One of the things that impacts the performance of these blades is dried tissue, which is allowed to bake onto the blades during the autoclaving process. So I would always keep the blade in a pan of water when it's not in use. And we also do sell diamond knife cleaning blocks, which are used to clean off the debris on the blade should any settle on the blade. So again, right after use, retract it back into the handle, hand it to the assistant, and then the assistant can place it in a pan of water, and that keeps the blade hydrated until it goes into the autoclave. As far as cleaning off the blade, I would recommend calling our customer service department for a box of diamond knife cleaning blocks or sponges, which are used to clean off the blades, and they are simply hydrated, and then they become very spongy and they're very user-friendly to the blades. If you have any questions regarding any of the recommended usage of the Rhine 3D Diamond Blade, please feel free to give us a call at 800-637-4346, and thank you for your attention.